Imagine this. It is a normal afternoon inside a hospital. The emergency room is already busy. Nurses are moving between rooms. Doctors are checking charts. A patient is waiting for test results. Another is being taken upstairs. Somewhere else in the building, a baby is being born. A surgery is already underway, and patients in intensive care are being monitored minute by minute. Then the call comes in. Multiple ambulances are on the way. The details are unclear. There may be several patients. There may be dozens. Some may arrive by ambulance. Others may arrive in private cars before anyone can count them. In that moment, the hospital stops being just a place where people come for care. It becomes a command centre. Most people only see the front of a hospital emergency. Flashing lights, stretchers, doctors, nurses and waiting rooms. But behind the scenes, a much larger system begins to move. Hospitals prepare for these moments long before they happen. They build emergency plans for disasters, crashes, fires, storms, power outages, disease outbreaks, and sudden waves of patients. They run drills. They test communication systems. They practice clearing space. They decide ahead of time who gives orders, who calls in extra staff, who tracks supplies, who talks to emergency services, and who keeps the rest of the hospital running. Because when a mass emergency happens, the biggest danger is not just the emergency itself, it is confusion. If no one knows who is in charge, where patients should go, or which resources are available, a hospital can become overwhelmed in minutes. So the first hidden system that activates is command. Many hospitals use an incident command structure, which means normal operations shift into emergency mode. Instead of every department making separate decisions, specific people take specific roles. One person may oversee the response. Others manage medical operations, supplies, staffing, communication, safety, and coordination with police, fire, ambulance crews, public health officials, and nearby hospitals. This turns a chaotic situation into a chain of decisions. Who is coming in? How many beds are open? Which operating rooms are available? How much blood is ready? Which doctors are needed? Which entrances should stay open? Which areas should be locked down? These questions have to be answered fast because the first few minutes can shape the entire response. The next problem is space. Emergency rooms are often crowded even on normal days. A hospital may already have patients in exam rooms, patients waiting for beds, ambulances lined up outside, and staff working at full speed. Then suddenly, more patients are coming. So the hospital starts creating room. Stable patients may be moved out of the emergency department. Some may be admitted upstairs. Some may be discharged if it is safe. Non-urgent procedures may be delayed. Hallways, conference rooms, waiting areas, or other pre-planned spaces may be turned into treatment zones. This is not random. The hospital is trying to create a flow before the wave hits. The most critical patients need immediate care. Others need quick evaluation. Others may need monitoring, basic treatment, or information. This is where triage becomes one of the most important systems in the building. Triage is the process of sorting patients by urgency. In a normal emergency room, patients are already prioritized based on how serious their condition is. But during a mass emergency, triage becomes even more intense because the hospital has to use limited time, space, and staff in the way that saves the most lives. Patients are assessed quickly. Who needs life-saving treatment right now? Who can safely wait? Who needs surgery? Who needs scans? Who needs oxygen, medication, blood, or transfer to another hospital? This can feel cold from the outside, but it exists for one reason: to prevent the system from breaking. If every patient is treated as equally urgent, the people who need help immediately may not get it in time. So triage becomes the hospital's traffic control system. One patient goes to the operating room, another goes to intensive care, another goes to imaging, another is treated and released. Each decision affects the next one. If too many patients are sent to the same place at once, that part of the hospital can jam. So staff use categories, communication tools, and pre-assigned roles to keep people moving. At the same time, the staffing system activates. The doctors and nurses already inside the hospital may not be enough. Alerts may go out to off-duty staff. Surgeons, anesthesiologists, respiratory therapists, pharmacists, lab workers, security officers, cleaning crews, transport teams, and administrators may be called in or placed on standby. In a mass, Emergency, almost every department matters. Housekeeping helps clean rooms quickly so new patients can be brought in. Pharmacy prepares critical medications. The lab handles urgent tests. Imaging teams prepare for scans. Information technology keeps phones, computers, and communication systems running. Security manages entrances, crowds, worried families, and sometimes media outside the building. A hospital during a mass emergency is not just a medical facility. It is a living system where every role connects to another. Supplies become another hidden battle. A hospital depends on oxygen, blood products, IV fluids, medications, bandages, monitors, ventilators, protective equipment, surgical tools, and hundreds of smaller items that most people never think about. On a normal day, supplies move through the building in a steady rhythm. During a mass emergency, that rhythm can suddenly be pushed to its limit. Blood banks may prepare for increased demand. Emergency carts may be moved into position. Equipment may be pulled from storage. Pharmacy teams may prepare trauma medications, pain control, antibiotics, or sedation drugs. Supply teams have to know what the hospital has, where it is, who needs it, and how quickly it can get there. Sometimes the most important question is not, do we have it? It is, can we get it to the right room in the next 2 minutes? Communication is just as critical. Inside the hospital, leaders need constant updates from the emergency department, operating rooms, intensive care units, radiology, labs, security, and administration. Outside the hospital, they may be talking with ambulance services, police, fire departments, emergency management centres, public health officials, and other hospitals. This matters because one hospital cannot always absorb every patient alone. Ambulance crews may be redirected based on capacity. Nearby hospitals may accept transfers. Specialists may be located at different facilities. If one emergency room is overwhelmed and another has space, the system needs to know quickly. That is why hospitals are not isolated during major emergencies. They are part of a larger network. But patients are not the only people who arrive. Families come too. In a major emergency, people rush to the hospital looking for loved ones. Phone lines fill with calls. Waiting rooms become crowded. Emotions run high. News crews may appear outside. Staff have to protect patient privacy, control access, maintain security, and still give clear information when possible. Many hospitals plan separate spaces for family updates, reunification, or media communication because they know a mass emergency is not only medical, it is emotional, public, and logistical. And while all of this is happening, the rest of the hospital does not stop. Babies are still being born. Intensive care patients still need monitoring. Surgeries already underway still have to continue. People with heart problems, cancer, infections, kidney failure, and other emergencies still need care. A mass emergency does not replace normal hospital work. It lands on top of it. That is what makes hospital disaster response so difficult. The building has to stretch without snapping. The plan gives everyone a starting point, but reality almost always brings surprises. Maybe roads are blocked. Maybe communication systems are overloaded. Maybe patients arrive without identification. Maybe staff cannot get to the hospital. Maybe the emergency involves smoke, chemicals, infection risk, or power loss. Maybe people arrive before the official alert does. That is why hospitals drill again and again. They are not practicing because they expect everything to go perfectly. They are practicing because they know it will not. The goal is to build a system strong enough to adapt under pressure. Eventually, the first wave slows down. The ambulances stop arriving as quickly. The waiting room begins to settle. The command center starts looking at what still needs to happen. Patients need ongoing care. Families need answers. Staff need relief. Rooms need to be cleaned and reopened. Supplies need to be replaced. Records need to be completed. Then comes one of the most important parts of the process. Review. Leaders ask what worked, what failed, where delays happened, whether communication was clear, whether supplies were ready, and whether staff knew their roles. Every emergency teaches the hospital something. The public may only see flashing lights and emergency doors, but behind that visible response is a hidden system of planning, triage, staffing, logistics, security, communication, and split-second decision-making. A hospital preparing for a mass emergency is not just preparing for more patients. It is preparing for uncertainty. It is preparing for fear. It is preparing for the moment when normal routines are no longer enough. And when that moment comes, the goal is not to make the hospital look calm. The goal is to make the response organised enough that people can survive it. Because in a mass emergency, every minute matters. Every decision connects to another. And the hidden systems behind the hospital can become just as important as the medicine itself. This is Systems Atlas. Subscribe to explore more of the world's hidden systems.